Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Good morning and welcome to Pedo Teeth Talk, where we bring you the contemporary issues important to you in your practice. We're here live recording at the annual session of the American Academy of Pediatric Dentistry in Honolulu, Hawaii, at the Tech Bar in the exhibit hall. This is kind of neat. We have a lot of people surrounding us, and we have with us Dr. Jeanette MacLean from Glendale, Arizona. Is that where you're from,
yes.
Jeanette? And
good morning.
Yeah, we're glad to have you. Man, there's so much to talk about, and, you know, I'm going to start by saying, well, I think you're here today, my audience, and those who are listening, because we're going to talk about silver diamine fluoride, this phenomenon. But we're also going to talk about medical management of caries, and silver diamine fluoride being in the context of that, and resin infiltration, which is in the same category, that we can treat lesions without drilling.
Minimal
intervention. So we're going to talk about all that. But before I go there, Jeanette, I'm going to ask you a lot of things about how you got into this, because it's really an interesting story. But I pick up the program today that we all pick up, and I just open a page randomly, and there you are. You gave a breakfast rounds this morning. I'm going to go to page 23 in the program, and it says, Blackjack Breakfast, getting parents to go all in on silver diamine fluoride.
I give credit to Jonathan Lee for that clever title.
It's a great, I need to hire him for titles.
Yeah, he must be a gambler.
I guess. But right next to you was arresting dental caries, silver diamine fluoride, a non-invasive technique. And then I go to the other side, and then Tim Wright presented yesterday the new guidelines in SDF. And then I think you mentioned, and I looked, and 10% of the posters are on silver diamine fluoride.
Yeah.
I've never seen a phenomenon like this in the history of my career over 30 years. It's taken over so quickly. And that's kind of what I want to talk about is, you know, I'll just start by saying, tell me briefly about your practice. And then tell us about how you migrated into this field.
Yes, excellent question. So I am in private practice and a private practice owner for 13 years now. And I think in 2014, I first heard of silver diamine fluoride in an online publication.
So only like 4 years ago. Yeah.
And my initial reaction was like, is this like charcoal toothpaste? Is this like some new weird hippie stuff? Like, I was highly skeptical of it because I'm a creature of habit and very type A. You know, I'm in this like sort of ritual of how I approach things, and I'm highly skeptical of new treatments, especially because I'm treating children. Like, I don't want to experiment on kids, and I want to make sure
it's not a flash in the pan. This
correct.
Is something that's
but I kept hearing about it, and then it made me think, well, gosh, there must be something to this. So when I started really reading further into it, there's a couple key articles, the UCSF protocol, which I think many of us now have read, and then Steve Duffin wrote in 2012 an article for the California Dental Association called Back to the Future, an introduction to the medical management of caries.
Right.
And when I saw that there was so much history and literature to support this option, I thought, well, gosh, this is great. I want to know more.
were you doing what you now know and you describe as medical management of caries in your practice before you heard about silver diamine fluoride?
I think it was a growth in me as I have matured as a practitioner. I think another big change for me was becoming a mom.
Tell me about that. How did that affect this?
Well, it made me more empathetic with the parents because when I was early in my career, I honestly felt I was more dismissive to parents' questions or concerns. Like, I found maybe it was an ego thing or maybe a self-confidence thing where I was frustrated when people would question me about things. But then when I had my own children and my daughter had surgery at 9 months old, and it's like I was on the other side of the table where I had all those fears and all those questions, and it made me realize, like, I need to take the time to acknowledge and engage the parents in discussion of treatment options, and I feel like it made me grow as a practitioner.
That's fantastic. So this concept, medical management of caries, and you talk about minimal invasion, there are a lot of kind of related terms. Tell me what that means to you and how you've embraced it, and what were the life events, you kind of talked about that.
Yeah.
That caused, it sounds like your practice, you've embraced this concept.
Right. Well, I think the main thing is the concept to treat or approach treating a disease, caries, as a chronic disease, which it is. Caries is a chronic disease for which there is no cure. SDF is not a cure for caries.
It's managing
it's another treatment option.
Right.
And what's great about it for us as pediatric dentists is it is minimally invasive. And the concept is that you're treating this chronic disease with medicine first, like being a topical antimicrobial, or let's say with glass ionomer cement or bioactive materials where you're treating a chronic disease non-invasively, non-surgically, whereas initially I was just doing the surgical intervention,
right.
which is
most of dentistry.
That's
most of dentistry is that.
And which I still do.
Yep.
And it will never go away.
Right,
and
it won't.
you know what's interesting is that I think initially, like me, highly skeptical when people first heard of silverdiamine fluoride. I think for a lot of people, one of the first major exposures to it was the New York Times article.
Yeah.
And there was almost like I don't want to call it a backlash,
2 years ago,
but just
I believe, yeah.
this moment of thinking like, well, what does this mean to me in private practice? Is this going to affect my business? Is this
It's like when they said that fluoride's going to wipe out decay 30 years ago.
Right.
No more decay. And, obviously decay's gotten worse because diet trumps everything, as we know.
Exactly. So, I think it's critical for people to understand about SDF and to understand about me and my approach is this is just one more item on the menu that I offer. I still do all the good pediatric dentistry, restorative dentistry, crowns. I still do sedation. However, now that I have minimal interventions like interim therapeutic restorations, glass ionomer cement,
more choices.
icon resin infiltration, things that are less invasive where I can conserve natural tooth structure, it's more options to offer to parents, and it really resonates with them, and they like... They'll say, I like that you're on the cutting edge of science and you're thinking outside of the box.
So speaking of parents, and, it sounds like this has enabled you to have a more, I would call it, authentic conversation with parents.
Absolutely, because it allows us to have that discussion of what is the etiology of the disease. Because I think many parents look to us as the doctor, or their dentist, that we're somehow going to cure their child of disease.
Right.
They think, well, gosh, how can my kid have cavities? I come every 6 months and get my teeth cleaned.
Right.
No, I'm not going to cure your kid of cavities. It's what you do every day in your home, what your kid eats and drinks, what is your hygiene routine. That's what's going to, quote, cure and control the disease. I just provide treatments, and these are the treatment options. I can do SDF. I can do restorative. It
makes you a better counselor.
Exactly.
I want to drill in, because we have so much to talk about.
No
we have
pun
limited
intended.
time. That's right. No drilling. But we're going to hone in on the subject of how did you introduce this into your practice? So you decided, okay, this is going to be for me.
Yeah.
In a short time, how do you make it work? How do you communicate it? How do you charge for it? All those things.
My advice is to start small.
Okay.
I started slowly and cautiously, very careful case selection. I found what seemed to be the ideal candidate was a little boy who had just 2 lesions, and he would have been a general anesthesia due to a heart condition. He wasn't a candidate for in-office IV sedation. And the mom said, is there anything else we can do? Because it was going to be $2,000, $3,000 just for the general anesthetic in the hospital setting. And I thought, well, actually, yes. Yeah. There's this new thing I can do.
That thing.
And I was insecure about it because I thought, is this parent going to think I'm like some nut and I'm experimenting on their kid? And I was pleasantly surprised and have been pleasantly surprised at the reception of parents and that they speak so positively about it. They think, wow, I'm so glad you keeping up, that you think outside of the box, you're on the cutting edge of science.
You're giving them another option.
Really like
you're not just saying this way or the highway.
Exactly.
You're saying, here's another way, and maybe we have to go back to the other way later, but for now, this is the right thing today. This is a great option today.
It's an option, and it's not for everything. In pediatric dentistry, there will always be a need for sedation and general anesthesia.
Yes.
Sadly, a lot of these kids are getting to us when it's too late, and you have to do pulps and crowns, and you have to do extractions, and you have to do the sedation, but I have been able to reduce it significantly.
So how do you, this stuff turns the tooth black. It's actually a Caries indicator when it turns black. And the other day, I have to say, you and I were talking about this, Jeanette. Somebody said I shouldn't say it turns black, it just discolors, and I said, from now on, I'm going to tell the parents, it changes your child's tooth to Pantone shade 591. See if that goes over well. But I think that we need to be direct about it, because it does turn black. I saw on your phone here, by the way, I'm holding up Dr. MacLean's phone, and it says, keep calm and paint it black.
Well, I have to give credit to my husband, who's wonderful and very supportive. Sometimes I don't know how he deals with me. He's got the patience of a saint. But I never saw out in life to do public speaking or anything like that. And quite frankly, it terrifies me.
You're good at it.
So, fake it till you make it. But, I felt that because of the New York Times article, all of a sudden I was getting inundated with calls and emails from all over the world on a daily basis, still to this day, wanting to know more information. And I just felt this calling that I needed to help my colleagues. And a lot of my friends, I'm like my cyber friends, like I know through, say, Facebook or Dental Town, where I like collaborating with my colleagues because we learn from each other. And this is the one thing that I can help my colleagues learn more about, or even maybe introduce or give them the confidence to try it for themselves. So he did that as a little surprise gift to me to give me confidence.
So how do you talk to the parents about the black stain and the outcome, and then tie in the restorative part to this a little bit, please?
Right. Well, I'm going to back it up. And the way the conversation normally goes is first we say your child has these cavitated lesions, or they have cavities. And if I think that SDF is an option, meaning there's not pulpal involvement or it's not grossly decayed, or let's say they're under the age of 3 and maybe I want to delay or avoid sedation, I will say now we have a new option where I can treat these lesions with a topical medicine versus going to the surgical intervention, which is the filling or the crown, and it's called silver diamine fluoride. And then I actually give them a copy of the New York Times article, because parents are skeptical too, and they're thinking like, well, some of them are thinking, what is this new thing? But it gets them interested, and
you need
it helps
a Wall Street
open that
Journal version too for the parents who don't read.
There you go. But they think, oh, okay, well, this is neat, and then they're curious to hear more. And then the next thing that I do is I get out. I have it's called a SDF chairside guide, and I have it as a free download on my website. So just again, as a resource to help my fellow dentists and pediatric dentists, where I show them before and after images of the teeth, and I have no issue calling, like, yes, it's going to stain the caries black.
Pantone 591.
Right. But to me, it's, there's beauty in the simplicity of it, and healthy is beautiful, and we have to get over the
and it's
color
an indicator.
aspect.
It's an indicator of efficacy.
Right. Well, and then the irony is it kind of shows the parent, like, there is disease
there
present
it is.
here.
There's the biofilm was there.
It's a reality check.
It's the bear's footprints.
Yes. But that you need to make changes at home, or this disease is just going to continue to happen.
I'm imagining, we see and others see, that parents don't object too much at all to the posterior teeth. But with the anteriors, how do you deal with the anteriors? Where you can clearly see it afterwards. What do you tell them in advance? Then how do you deal with it afterwards?
This is the thing. I think that we have an obligation to present it as a treatment option, because that's our due diligence to give informed consent, risk, benefit, and alternatives. So I present it as an option, and I never want to put my own assumptions onto the parent. I don't want to assume that they're not going to be okay with the aesthetics. They have to decide what do they want for their child. Do they want SDF as a time buyer until the child is more cooperative and I can do an aesthetic restoration?
Right.
Do they want to go ahead and do the sedation now and do something that's more definitive and aesthetic? It's up to them, and it's pleasantly surprising how some of the most educated, wealthy parents literally will drive across town to just have SDF to avoid or delay sedation, and they don't care that it's dark.
I've seen that too. But what if they do care? Then what do you do in that situation? Well,
I then show them another little page in my handout, as I have a little presenter on SMART, on silver modified atraumatic restorative treatment, and I show them how I'm able to mask the black scar using glass ionomer cement, and it's actually what I'll teach tomorrow in the string of pearls.
That's a pitch. Go to string of pearls tomorrow. You can hear her talk about it. Okay.
So if they're on the fence and they're thinking, well, maybe I do want to go ahead and do the restorative, or maybe I want to do this as a treatment alternative, when they see that, a lot of times they'll say, oh, okay, well, that's fine. And they'll consent to that. But then if they still don't want it, they still have the option to do restorative right out the gate.
Yeah.
But let's say they don't, maybe the child can't cooperate and they do want to buy some time. We shouldn't forget that we still have interim therapeutic restoration, or I still call it.
All these options.
Yeah, you could just use glass ionomer cement.
It seems like to me when I'm listening to you talk, and it's a great way to have the conversation, I'm learning from you about how we can modify how we do it. in that it sort of provides a way to get better informed consent.
Exactly.
Because informed consent is, what is the risk of this? What is the risk
Yes.
of the alternative? What is the risk of doing nothing? And by talking about it the way you do and bringing silver diamine fluoride and the other options and
Yes.
giving them the choice, you're actually having an informed consent conversation.
Yes, and it's empowering. And the parents genuinely appreciate and have expressed to me that they appreciate that I took the time to explain the etiology of the disease. They want to of course, there's some people who are like, yeah, what's the total?
Yeah.
Give me the bill. I want to leave.
Right.
But there are many well-intended parents who
Yes.
genuinely want to know, how can I make this better for my child? How do I prevent this from happening again? How do I prevent this from happening to my newborn,
Right.
what has happened to my 2-3-year-old?
Yes.
And they appreciate, and what I see a lot of second opinions.
Yeah.
And what they'll express is, gosh, at the other office is like, I got a treatment plan and a sticker,
Right.
and then, or I was presented only
They
one option.
appreciate the conversation. They
Right.
appreciate the conversation, the time you're taking to talk
They
to them.
feel empowered.
Thoughtful, yeah.
Right. And that's of critical importance to me is I feel that we owe the parents
Yeah.
that time. Because we're not just carpenters of the teeth; we're their
Right.
we're their physician of the mouth.
I think that's the best part is that this has, and I would sense just listening to you today, Jeanette, and we talked about the transformation of you and your practice, that it really has, I used the word authentic before, because you are now engaging your parents in a much more profound way.
Yes.
Because you have the authenticity and they feel that. And it's not even about silver diamine fluoride anymore, because
Right.
that's an option.
It's
You're
just
having
an
a
option.
conversation, and I
Right.
think it's great. I want to keep moving along here and talk about how do you bill for this?
Well,
Have insurance
we have
companies paying for it?
a code,
Okay,
D1354,
1354,
per tooth.
okay.
And I charge similar to our fluoride fee per tooth each time that I apply it, but you'll hear things all over the board.
Right.
And I think getting close to 50% of Medicaid programs are covering it, and I'm fortunate
And
to
growing,
live,
I think.
Right, and
Yeah.
I'm fortunate to, and I should mention, I really credit and really appreciate what the AAPD did with their guideline.
Yes, helped a lot.
And I'm grateful to them for all the
Yeah.
work that they put into that, because
Yeah.
that, without a doubt, is going to help the
Thumbs
payers.
up for the guideline from
Yay,
APD.
Thank you.
Yeah.
So that is going to help the payers hopefully
Yes.
start reimbursing more. But what I find is, because
It'll
I keep
happen.
it a reasonable fee, most parents are more than happy to pay out of pocket for the option.
So I want to circle back, so, and talking to insurance companies and what they pay, they're always concerned about overtreatment and overuse and all
Yeah.
this. I want to get back to what you said about the conversation, and I forgot to ask you, do you document that conversation?
Oh, absolutely.
In the notes, you
Oh,
talk
yeah.
about the interaction and what you
Yes.
said and what they said, and that sounds like that's
We
a pretty
have
important
to.
part of this process, right?
Right, because some of
Documenting
these
that conversation.
some of the parents have amnesia. You
Oh,
never
really?
told
I've
me
never
that.
seen that.
Yeah,
I guess I have
Their
amnesia.
parents can be poor historians, or
Yeah.
I like to call it the telephone game. That maybe one parent comes to the exam and then the other parent calls back the next day all angry, like, well, what's going on? So it's important to have that documented in the notes. Like, what was the discussion?
Right.
What were the options given to the parent?
I want to shift a little bit in the latter part of our conversation today. I wish we could stay all day, but we do have a short time today. There's a lot of other stuff at this meeting, as we said, on silver diamine fluoride. I think you're talking about it again at the meeting. You're talking about the SMART. Is that later today?
Yeah, the string of pearls tomorrow, and then the
String
new
of Pearls
dentist
tomorrow,
course today.
New dentist course, and then there's so many other opportunities. And I love the fact that we're getting more about this medical management of caries, and
Yes.
it's changing, as it did for you, the way we think.
Right.
So I want to talk about resin infiltration, because that's also in the continuum of medical management of caries. I want to know, I'll ask you the same way I did before. How did you hear about it? How did you decide to do it? How do you bring it into your practice and the conversation with parents?
I give credit to Rick Chait for introducing me
Yeah, Rick's
to
like
Icon.
a machine with that, isn't he?
Yes. And so I believe it was maybe in 2013. So I've been doing it 4 or 5 years now. And again, I started small and cautious. Like, I started small and cautious with SDF, as this is another option I can offer. And when I saw the excellent results and how happy the kids and the parents were, I do it quite frequently now, especially for anterior lesions. So we have some congenital enamel defects, which it works very well on, and then also post-orthodontic white spot lesions. And then, of course, you can use it in the posterior. So let's say you have a teenager with several incipient lesions post-ortho, but they have gum line decalcification.
Yeah.
Sure, SDF is an option, but the concern there was if it's going to creep and wrap around to a visible area along the
those
buccal
are
gum
tough
line.
ones to deal with. Yeah.
You have icon resin infiltration, which you can place interproximally. And we have the new ADA non-surgical guidelines that are going to come out
Right.
later this year.
That's right.
I know Rebecca Slayton was working on them.
Yes, that's right. Some of the diagnostic criteria will be available.
And that's one of the recommended treatment options for incipient enamel lesions is to do the icon resin infiltration.
Yes. Yeah, there's a lot of it's been around for a long time. The clinical studies are outstanding, and I think it's seeing a lot of traction suddenly for the various reasons.
Well, we spoke earlier about the online community, and there's incredible interest and word of mouth about icon.
Yes.
Online, and that's another way I feel I've been able to help colleagues is show examples because I've done so many cases now, and a variety of cases where I can show them the results because. Like SDF, not every tooth it's not an option for every tooth to do icon. So
depends
some
on
of
the situation. Yeah.
Challenges we'll see are some people maybe weren't using it correctly or not doing good case selection and weren't having the same kind of results that I was having.
Yeah.
So
case
I'm
selection,
able to share.
I think you mentioned sharing that, and there's this website that many of our colleagues know about, IPEDO it's called, and I don't post much because I just don't want to start. But
you're an IPEDO stalker.
I'm a stalker, yeah. I guess I stalk my kids. I stalk my kids on Facebook, and I stalk IPEDO pediatric dentists on Facebook. Whatever, be that as it may, I think it's amazing how quickly somebody posts a case, whether it's on SDF or an icon, and they're similar in that regard, and then you'll have 27 comments in the first 20 minutes.
Yeah.
It's like, if I don't look at it right away, I'm late. I'm like, they're on to something else. It's amazing. It's a perfect way of communicating a lot of information quickly. Now, the question I have, though, is how do you vet, how do people know what's correct and what isn't, and what's valid and what isn't, and that's the downside.
Right. And
that's why we come to this meeting, is we get good information here. But
well, and that's always been my thing, is I want to do things that are evidence-based, and maybe I give TMI, but I will normally try to refer back to literature to support what I'm saying. So I feel that now at least I've developed
how do the readers
reputation for having good information, but you're right. You have to discern.
But many of the posts don't have that.
Correct.
From many, and so I think it's important that we corroborate our information.
Yes,
I love.
Absolutely.
I mean, don't get me wrong. I love that site. I take things from there and I use them in lectures and the pictures and the outcomes and clinical cases. And I think what people do in their real practices in real life is actually sometimes way more important than our controlled circumstances.
Right, but we need to do our own due diligence to read the literature.
Exactly,
because you're not going to get in a soundbite online. The proper clinical protocol, the proper case selection for a procedure. It might inform you that this option exists, but we owe it to ourselves and to our patients to educate ourselves properly, read the literature for ourselves, and know what we're doing instead of just
I have to say, my favorite thing on that site is the people kind of one-upping each other on who had the most uncooperative mom or child.
Well,
the story of the week. They ought to have like a story of the week. Well, I can show you a better one than that.
Right. Well, the other nice thing is it's like group therapy.
Yeah.
Because I can come home and complain about a bad day to my husband, and he goes, "Oh, I'm sorry," but no one really gets it or appreciates or can empathize like our fellow dentists and pediatric dentists. Like we can commiserate.
That's right. So back to the resin infiltration for a minute, just to finish that. How do you present that? I mean, you kind of said it, and then how do you charge for it? I want to just close that loop.
I see it both ways. Sometimes the parents are coming and patients are asking, gosh, I have these spots. What can I do about it? And then I'll present it. So I actually keep a binder with information handouts. I have an article from the Journal of the American Dental Association that talks about icon resin infiltration. So if they're like the engineer or the nurse parent that want to see the facts, I'll give them the article to read. And then I have I keep an album of before and after images so I can show them the best result, the medium result, because not all lesions reverse completely. But they love the idea that they can, with minimal intervention, have a significant aesthetic improvement, especially if the child is young, where maybe they have something really severe that as an adult or young adult they might need a veneer. This is something they can do right away because maybe the child's being teased at school.
What about the interproximal ones that are not about aesthetics but about caries stabilizing?
Me identifying the problem and bringing it up to them and presenting options on how we can treat it. I should also mention I've had people come to the practice because they knew from looking online that I offered it as a service. So I suggest to everyone, use your websites to your advantage, use social media to your advantage.
Talk
and if
about
you
what you do.
offer an option that maybe your peers aren't offering, like SDF or SMART or even Hall Crowns, Icon, resin infiltration, let people know that you do it, and you'll be pleasantly surprised at how many people will come to you for those options. I'll even have people out of state ask me, do you have an Icon provider in Northern California? Because people, the power of the internet, they're finding out that this is an option. So some people are coming to me for it, and then other times I'm identifying a candidate for the treatment option, and I'll inform them of the option, because maybe they didn't even think that there was anything they could do about it.
Right.
And I'll say, gosh, these spots, do those bother you? Because I have this treatment that I can do to help eliminate or lessen the discoloration that you have.
So as kind of a final point, and I wish we had longer, but I want to ask you just one more thing, and then we'll open it up for a couple questions if there are any. Pediatric dentistry in 2018, we talk about a paradigm shift, and I've been talking about medical management caries for 25 years, but it was maybe premature. We didn't have silver-diamine fluoride. We didn't have resin infiltration. I'm just heartened by the fact that we have you self-described, never wanted to lecture, we're afraid of lecturing, and you've embraced this because you saw it and you told us about that a minute ago, and you're in the younger generation of pediatric dentists. You're going to, you're in that cohort that is going to be the change agents for the future of our specialty. So would you describe what you talked about today as a wave? We're in Hawaii, going to talk about a wave that's never going to dive in. It's going to keep cresting, right?
Right. Well, I think
on change in dental practice.
I feel that we should embrace new and emerging technologies, and in this case, at least with SDF, it's really old technology, but say Icon resin infiltration. We have to remember that our education didn't end when we graduated dental school. It was really just the beginning, and science is ever evolving, and it's something to be excited about, because having new options, it doesn't mean you have to stop doing anything that has been tried and true for decades in your practice. It's now you have more things that you can option or offer, and then you have more ways that you can help your patients and more ways you can help their families. And that's, I think, what's been beautiful about introducing SDF and Icon is I can help so many more people. So it's just enhanced my practice. It's one more thing on the menu. I still do traditional restorative dentistry. I still do sedation, but now I have more options. And I find that people who maybe were resistant to come to the dentist, maybe out of fear, another evil of social media is you hear negative stories like about Medicaid fraud or adverse outcomes. And some people are avoiding coming to the dentist. So when they know that you offer something new and different, it's amazing. It's an amazing practice builder, because I've had many people comment that they came to see me because I offered something new and different. And maybe it's not an option for them, but they just like that I was open to the idea of doing different things.
And it's about coming to this meeting, staying in touch, you spreading the word, us learning from you, and everybody learning from each other, and finally embracing new things. Yesterday, I interviewed Nestor Kohenka, who was speaking here on vital pulp therapy, and I'm relating it because I asked him the question. I said, Nestor, should we throw away our zinc oxide eugenol and calcium hydroxide and keep only MTA? And he said yes. He said that. So we got it on Pedo Teeth Talk. And
my slogan is take nothing out of your toolbox.
Yeah. So we add to our toolbox. We add new ways to our toolbox.
Get the jumbo size on wheels.
I want to thank Dr. Jeanette MacLean for being here with me today. You've had a great audience here today. Now, if there are any questions, we could take a couple. Are there any questions? Come up to the microphone, please. Come all the way up and speak directly into the microphone. We have time for one or two questions. And just put your mouth right on that microphone, if you would. Okay.
All things being equivalent, posterior interproximal incipient lesions, which modality would you choose, Icon or SDF? What's more efficacious?
I think you need to offer both options. And remember, another option is to do no treatment, especially if it's incipient, changing behaviors, what you're eating and drinking, fluoride, maybe 5,000 part per million fluoride toothpaste, getting a better hygiene with the patient. That's an option too. But then I give the option of we could do SDF in approximately. They have to understand the color change, and I show images of that. Some people may be more hesitant to do it in permanent teeth. I find high acceptance in the primary dentition to do interproximal SDF because they don't care that there's going to be a color change. But with the permanent teeth, especially post-ortho with gum line decalcification, then you have to have that conversation that maybe this is a better case for Icon if aesthetics are going to be a concern. So I will present the options and then let the parent decide what they want to do.
If it was your own child, what would you do?
I have done SDF on my own daughter. I've done it on myself.
I've done it on. I have 6 kids. I've done it on 2 of them.
For hypersensitivity, I use it on myself, and it won't stain sound enamel. And I had night and day improvement in the sensitivity that I had.
You do that in the dental chair on yourself?
It's funny. I have photos of it. So I had, because I was afraid. Well, what if it does accidentally stain? My assistant isolated and dried, but I officially put it on my own too, so I could only blame myself. And I'm happy to report no stain, but significant improvement in the symptoms I was having.
We're not going to call that DIY dentistry.
It was DIY dentistry.
Yeah, I've seen the guys with the Dremel tools. If you go to YouTube, you can see a lot of that stuff. Yeah.
But and then for my daughter,
better than a Dremel.
For my daughter, she had a fissured groove on T that I was like, I don't like the way that looks. So I did put SDF on it. And it's funny because she sees the color and boy, does she brush that tooth. Like she's like, So it's funny.
That's cool.
I think it's enhanced her hygiene. But I would use it. I would do both treatments on my children. It just depends on the scenario.
Yeah. Another question, please. Speak right into the mic.
I was curious what your practice makeup as far as like Medicaid, PPO.
Oh, yeah,
and
that's a great
then what do you
question.
bill for Icon?
Sure.
And kind of how does that look from an insurance standpoint or a cash standpoint?
Yes.
So the couple questions were what is the makeup of your practice, payer mix, and also how do you bill for Icon?
We're roughly 20% Medicaid, and then we have roughly 5% cash or no insurance, and then the rest are private PPO plans. And as far as Icon, the code is $29.90, and I charge similar to a one-surface resin.
That's what it is, so it's a good way to charge.
And most of the time it's not covered by insurance, but when I take the time to explain the option to the parent, explain the benefit of it, and show them before and after images, the majority of them consent to the option and are happy to have the option.
I think Rick Chait told me he's done 300-400 of these, and he's only had one parent turn him down. Fee cash payment. They all say yes. Maybe he's a good salesperson. I don't know, but he's
well, I bet he's well informed.
He's well informed,
and he's confident, and that's part of it. And I think that's when we do our due diligence to read literature. It makes us confident, and then when you present an option, the parents sense that in you and do. Yeah. Agree to treatments for even if it's not
confidence
covered.
Is important. We'll take one more question, please.
Yeah, I'm a IPEDO stalker too, and
all right,
go stalkers.
So I see you on there quite a bit, and when they talk about anterior hypoplastic teeth with more opaque brown and yellow staining, the etch bleach seal.
So that's another option too. And sometimes I call it the combo platter, where I will etch. And maybe the brown isn't going away, so then I will rub the surface with sodium hypochlorite. But then I do like to seal the surface. So you could use
you're using a Delton sealant there? Okay.
Right.
And then you just keep going multiple rounds with etch and bleach?
I think some of the mistakes people have when they're not having good results with those types of cases, like an Icon case, or if you're doing etch, bleach, seal, is either they're doing it too close to a professional fluoride application, and the enamel is so resistant to acid that your etching is going to be insufficient.
Okay.
Or maybe they're not etching enough times. They might do maybe 1 or 2 rounds of etch. You really should be doing at least 3. And if I don't see a change where if I'm placing the drying agent, which is ethanol, if I don't see that lesion disappearing, at that point I will take a softless disc and smooth the surface and then etch again. So, not etching enough time.
So it's a matter of just kind of looking clinically and seeing if you're getting the results when you're putting the drying agent on it.
And knowing that, again, it's not for every tooth. And so let's say some incisors with really bad MIH, or that defect is through and through, it's not going to be adequate. It doesn't hurt to try.
Yeah.
And sometimes you can improve the aesthetics, but maybe that's something where you might want to do a resin veneer.
Gotcha.
Especially if they're being teased.
Yeah.
That's an option.
Okay.
Well, thank you for your question. Thank you for all of you for your questions today. God, I learned so much. And, Jeanette is great about answering questions. I'm not going to speak on her behalf, but she always answers everybody all the time. I'm her agent, so you got to go through me. But I'd like to be her agent. That could be a good job. But in any case, thank you for being here with us today on Pedo Teeth Talk, and thanks to our audience, and thanks to those tuning in who are hearing this later on. And it's been a pleasure to bring you from the American Academy of Pediatric Dentistry Annual Session here in Honolulu at the Exhibit Hall, Pedo Teeth Talk. See you later.
Thanks, Joel.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.